In these 3 short videos, we're going to talk you through the assessment of syncope and the syncope pathway. Syncope is a common presentation to ED, accounting for around 1 in 50 presentations. First, we need to define syncope. Syncope is a sudden, temporary loss of consciousness associated with loss of tone due to global cerebral hypoperfusion. As always, we start with the history. History taking is the most important part of the assessment of syncope, and you should consider your differential diagnosis as you take your history. So that you don't forget anything, go through what happened chronologically. So thinking about before the event, ask them what they were doing at the time. If there was anything like a trigger, like carotid massage or pain, think about vasovagal syncope. If the patient was on the toilet, think about situational syncope. Had they just stood up? Think about orthostatic hypotension. Were they exercising? If they were, this could be concerning because it could suggest cardiogenic syncope. Still focusing on before the event, consider whether there was a prodrome. Ask them what happened immediately before they lost consciousness. If they had any typical warning signs of a simple faint, like feeling hot, dizzy and sick, this is suggestive of vasovagal syncope. If they had no warning at all, like a switch going off, this is more suggestive of a cardiac cause of syncope. Chest pain before a collapse could suggest acute coronary syndrome, aortic dissection, or pulmonary embolism. Palpitations associated with a collapse should lead you to think about arrhythmia as a possible cause. A severe headache just before a collapse could suggest a subarachnoid hemorrhage. Sticking with before the event, think about the wider context that the collapse happened within. Ask them how they had been earlier that day. If they had been hot or dehydrated or unwell with vomiting or diarrhea, this might make vasovagal syncope or orthostatic hypotension more likely. Find out if there was any history of bleeding, especially a GI bleed, which may be insidious. In women, think about menorrhagia. Find out their past medical history. Particularly find out if they have any cardiac history, as this might make a cardiac arrhythmia more likely. In a young woman, consider the possibility of an ectopic pregnancy. Don't forget to establish whether this has happened to them before. Drug history is also important, especially if they have recently started or changed a medication that may have contributed. Check if they are on anything that could lower the blood pressure or slow the heart rate. Whilst you are thinking about things that have been ingested, it's worth asking about recreational drugs, including alcohol. Ask about family history. Ask specifically about any family history of sudden cardiac death or drowning, because this could suggest an inherited cardiomyopathy or arrhythmia. Now that you have established the context and the events leading up to the loss of consciousness, you now need to find out what happened during the loss of consciousness. Witness accounts are very useful here. First of all, it is important to establish that the patient definitely lost consciousness, and that with it there was a loss of tone. If they were standing or sitting at the time, they will have fallen to the floor unless they were supported. So don't forget to consider any injuries they may have sustained. Establish the timeline of events. Ask if there were any shaking, tongue biting or incontinence, and if so, when these things happened. These features make a seizure more likely than syncope, though it is possible for some jerking movements to occur after a period of cerebral hypoperfusion. How someone feels and behaves after a collapse can give important clues as to what happened. A quick spontaneous recovery is more suggestive of syncope. A post-ictal period would imply a seizure rather than syncope. It is not usual for a stroke to present with a loss of consciousness, but neurological symptoms after a collapse may be suggestive of Todd's paresis. That completes your history. Move on to the next video to find out about examination and investigation of the patient with syncope.